About advantage of X-Fix, it's fast to set up, especially in emergency or trauma situation. Another point, it's also effective for stabilizing bone fractures, and it's also allowed to treat soft tissue injury or wound easily. And also it does not require large incision, so it's minimal invasive technique at the fracture site. And also it can be used as either temporary or final or definitive treatment. It's strong also enough to allow the patient to start put with bearing on the limb or loading, according also to the doctor instruction or progress in the X-ray. About this advantage of external fixation, the frame itself heavy and physically large outside the body, so the patient not comfortable. Second point about bacteria can enter through the pin site, and so it's high risk of infection. We called it pin site infection. It's common with external fixation. And also another point about over the time, the pins itself holding the bone from inside, it can become loose. So dynamization can help to solve this problem. The doctor can make it in OT and start to make dynamize for the roots itself and make the bone near together, so it's a start callus formation and start healing of the bone. Neurovascular injury, it's very common with external fixator, and potentially injury for blood vessels and damage for the nerves. It's happen during a placement of X-Fix. Muscle like immobilized lead to stiff in the joint and tight of muscle due to immobilization for at the first time, and soft tissue contractures may also happen due to immobilization as permanent. Next, please. In this slide, we will talk about BOP and external fixator general care. It is very crucial for monitoring the patient closely for the first day after applying a BOP cast, as we said, to check for any circular issue or swelling, and to take direct action, immediately action to remove it if we see any complication or any warning sign or red flags, we can say. Next point about patient shouldn't submerge or bathing the affected limb in the water, but he can or should maintain personal hygiene through a sponge or careful washing of the limb. And in generally, patients with these X-Fix require hospital monitoring and shouldn't be sent home immediately until they are stable. So we encourage the patient to stay in the hospital, but also because of overpressure settings or the capacity of the hospital not allowed. So we can discharge the patient, but we need to require discharge safely for the patient. Then teaching both patient and their family how to manage the X-Fix and recognize warning sign is vital point before they go home. So we can inform the patient about any sudden symptoms they can or warning sign can come back for ED, and the doctor will deal with that. Regular also medical check-up as the follow-up for removal, maybe for the X-Fix or follow. Also, it's should be considered and scheduled to monitor healing and eventually maybe remove the cast or external fixator safely. Last point in this slide, they talk about primary goals of rehabilitation should be the patient's ability to use their limb and perform ADL, activity of daily living, rather than just looking at the bone alignment in the X-ray. Back to you, Verena.
Thank you, Naveen. So fractures obviously have complications. One of the major complications are nerve injuries. So it is quite important, it's very important that this is assessed as early as possible. When a patient is in a cast, the circular cast, this is obviously much more difficult, but it's the physiotherapist's task to check for muscle activity or to check for nerve injuries to ensure that this is addressed as early as possible as well. When a patient is immobilized, one of the major complications are thrombosis, and therefore prophylaxis is the key. We talked about the importance of getting the patient out of bed and mobilizing as early as possible, and that is the best prophylaxis we can do. We also talked about the complication of compartment syndrome, and that is that compartment syndrome requires immediate intervention and most often surgical intervention. This is specifically important for crushed injuries where bleeding keeps happening when the tissue is damaged. So it's very important that this is addressed quickly and, if possible, within the first 6 hours to avoid permanent damage of the nerves. Pressure ulcers are also a big complication. Here we need to be careful when we have a patient who is immobile in bed, but also we need to make sure that we don't create pressure areas when we apply plaster of Paris, particularly circular plaster of Paris, or even back slabs in the initial phase of treatment. We just need to make sure that bony parts and sensitive parts of the bodies are well padded. One thing we maybe didn't talk so much, in MCIs, we don't do back slabs. We immobilize the fractures with Kramer splints till the patient can go to OT, or the very temporary solution. And here it is quite important that we put enough padding, that we pre-prepare the splints with padding to ensure that we don't create pressure sores, even if the patient is waiting for only a few hours to go to OT. The major complication of fractures in conflict settings is, as we've mentioned a lot of time up to now, infection. And as Naveen said, this infection prevention is a multidisciplinary duty, and it includes the whole team who works with the patient, and also, very importantly, the patient and the caregivers themselves. When we looked at traction, at the traction pictures, we typically say it's about 10% of the body weight of a patient. That we put the traction weight is about 10% of the body weight. This is, of course, quite difficult to be accurate about. Sometimes we may need a little bit more. Sometimes we may need a little bit less, depending on the soft tissue injury of the quadriceps. Here it is very important that we don't put too much weight on, so we stop the wound healing. Because one of the big problems of fracture management in situations of conflict, is the malunion. So we have it's very important to do a regular monitoring on X-ray to ensure that we have a callus formation and we are on the right track. In terms of functionality, one of the major goals, as we said before, is functionality and is including the mobilization or the function of all range of movement of the limbs of the joints. So having a good program, a good home program, and also a good in-hospital program to mobilize the joints and to stimulate the function is essential. I hand back to you, Naveen, for the challenges.
Thanks,